And so it's my honor to introduce our distinguished speaker for the evening, Dr. Ozanian Meireles, a true trailblazer at the intersection of AI and robotic surgery. Dr. Meireles is a globally acclaimed powerhouse in AI-driven surgical innovation, serving as the Vice Chairman of Innovation at Duke University School of Medicine and Surgical Director of Duke AI Health. As Director of the Surgical AI and Innovation Laboratory, or SAIIL, at Mass General Hospital, he pioneered the integration of AI, computer vision, and robotics to revolutionize surgical precision, efficiency, and safety. As chair of the SAGES AI Task Force, Dr. Meireles established international benchmarks for scalable surgical AI, driving transformative advancements in minimally invasive and robotic-assisted procedures. Positioned at the forefront of technology in medicine, Dr. Meireles' groundbreaking contributions are reshaping modern surgery and democratizing access to life-changing healthcare innovations worldwide. And so without further ado, Dr. Meireles.
Thank you. Thanks so much. Thank you. And all the founders here, and everybody who was attending the lecture tonight, for also the conversation after that, for your eagerness and desire to learn more about AI, because I think it's so important, us clinicians to be also engaged on this, not just be fed the information from industry or for our colleagues who knows more about the technical portion of that. So I think it's so important for us to embrace this. I know that the title is AI and robotic surgery, the future innovation of the OR, but I think it's super important to, be mindful about that. Robotic surgery is playing a minor role. What's going to happen in the next few years, and it is the cognitive augmentation that artificial intelligence gives to us that's going to be the big, breakthrough. So that's why I adjusted the sizes of the letters on the headlights over there. So let's start with this. We're clearly living in an era of technological disruptions. That's how we're going to frame this. We, from self-driving cars, very soon be able to get quantum computing, and ChatGPT will really make AI become popular. But the biggest question is, what is happening in the operating room? And what I would say is, to put into context, there was a few major revolutions in surgery. The very first one was general anesthesia, introduced it in the 1840s, which allowed us to do longer surgeries. And this is actually a drawing from the Ether Dome at Mass General. Then came antiseptic techniques that allows those longer surgeries, the patients to survive infections. It took 100 years that then minimally invasive surgery came. And with that, now we're seeing the next big thing, which is cognitive computing. And a new word comes in 2016, which is surgical AI. And surgical AI is being powered by all the data that's being generated by hardware, softwares, human operators, videos, among others. But one of the things that's very unique about surgical AI, when you talk about other AI in healthcare, is the fact that we generate so much video data, especially minimally invasive, robotic, endoscopic surgery. But not just that we generate so much video, we also have so much more powerful computing techniques that allow us to process them, and much more powerful and efficient techniques, such as the convolutional neural networks, that since 2016, the recognition of images, faces were better than humans. So I love Formula One, and let's just think about this. Formula One, they utilize so much of data, telemetry from the car, the tire pressures, the temperature, the speed, the other teams, what happened last year, the driver, car, weather situation, and they act upon the time, like in the real time about the information, right? They have some, and just to disclose, I'm a huge Formula One fan. That's why I have those things there. But I also learn a lot from Formula One. So before every race, right, each team has their analytics partner. So Red Bull has Oracle. And then what they do is they do like a race strategy, a race simulation. And they take a look at so many different data variables. For example, what are the sources? What's going to happen? What's going to be the stream? If this happened, how are we going to act that? And they look about race engineer 1, 2, 3, tire pressures and everything else. If you think about it, they could be the surgeon, the circulator, the first assistant, the anesthesiologist, so on and so forth. And they have actually won races in making decisions in a split of the second, right? So put into context again, a Formula One race with the 10 teams, the 20 cars, they generate about 250 terabytes in a day. An average hospital in the United States generates 137 terabytes per day. So then imagine all the hospitals combined in the United States or in a single city, how much more information generates from Formula One. But going back again, they are able to action on that data in the real time. We don't do that, right? Unfortunately, we throw the data away or discard. But like from the Marvel movies, what if, right? We could do that like an operative planning using all the data that's there and create a surgical strategy with air and handling recovery system, right? Like Formula One does for their cardiac teams. So just for off the shelf, some applications that are currently can be start right now with the technology we have would be data-driven insights, predictive analytics, automated scheduling for the hospitals, resource allocation, both from instruments and people, do some quality improvement, system notifications, generate operative reports, do the billing for us, do some compliance monitoring, and prediction of an allocation of other resources. Three big things here. Telementoring is already something that we can do with the current technology. We could start using some of the AI technology to trigger telementoring from a human, or operating case prediction. So anesthesia will be very pleased to be hearing from the insights from the machines about how they could be planning in real time on the day of the operating rooms. And something like attention awareness. I was just as the CES Las Vegas last week, and some of the companies are being sponsored, I believe, was by Panasonic, I think. They are putting in cars. I'm sorry, there was Kia and Hyundai. They have already attention awareness within their system. If the drivers start closing their eyes or moving or going to different directions, you get a warning. So imagine a surgeon that's fatigued or somebody that's not so skilled and actually focus on a different area it's supposed to be doing. We could have some notifications right there. But we have a lot of barriers to get there, right? Quality and privacy concerns always a problem. High cost to implement this, hard to integrate, a huge cultural resistance, especially to record the videos. At the moment, all the AI being developed, we cannot validate in different sites, so it's hard to have interoperability. And of course, ethical concerns, right? So being a research investigator, an innovator, I love to think about that we're creating a new technology, and we're creating a new field that's called surgical AI, right? And every time you think about how we're going to go from one side of the cliff to the other one and cross this chasm, there is a curve that everybody knows, a curve of innovation theory. Then we have the innovators, the early adopters, and go so on and so forth. Back in 2017, we were innovators. Now I can guarantee you there's a lot of early adopters. The magical number to cross the chasm is about 18% of people adopting this. And I think we are on the verge of this year or next year to pass to the other side. There are three major pillars of development for this, right? We have to establish community of users, which we know we have already. We have to design a legal framework that's going to be governing all those stakeholders, right? And we have several of them: the U.S. Government Act, the European GDPR, HIPAA, among others. But the most important thing is this: we still have to build this architecture framework. That's that bridge that helps us to cross the chasm, right? So this bridge, this will connect all the community, and then we're gonna move so fast and thrive and blossom from there. And how do we do this? Over the last several years, and then with my hat as a SAIIL's AI committee chair, we start putting forward surgical AI standards. There were three major buckets. We will call the foundation works, where there's standards for the annotation of the video, standards for the data structure, for the governance, understanding our structural needs, such as a video acquisition framework, create a community of users of this type of technologies, and know how to manage the data through the life cycle. And of course, the knowledge creation, dissemination through scientific meetings, education, and cultural transformation. I think the hardest of all of them is the cultural transformation, to make people understand what is AI, how to utilize AI, how to criticize AI in a thoughtful way. But let's go from the very beginning, how we constructed this journey, so you guys will understand is, first you have to be treating a surgical video like we treat like a tissue specimen. So if you collect the tissue in the operating room, it goes to a container, it goes to a pathology lab, right? Similar should be once you get a video, it goes to a USB or it goes to the cloud and then goes to AI lab. And then understand the complexity of the surgical video data. One thing that's important to understand is that the surgical video data wouldn't exist wasn't for not just the clinician, but the interaction of the clinician, the patient, the researcher, the industry. And then what we can do with this data is highly dependent what are the government's policies and oversights on different parts of the world, and different hospitals in a single city that might have different types of governance. This was the very first papers we published with under the SAIIL umbrella, which is the consensus recommendation of the annotation framework for the surgical video. The QR barcode over here, if you guys want to take a picture, that's the link to the video. I'm sorry, to the paper, and I highly recommend to read this to at least get some foundation on the annotation for the surgical video. We did this with a consensus of more than 50 people from both academia and industry, technical people and clinical people, no C-suites, no marketing people, just to get a truly scientific consensus to put forward. And what we found was there was two major elements of a surgical video: the temporal events, which, for example, right here you can tell that the gallbladder is being retracted, the cystic artery is being exposed and is being cut right now, gallbladder further retracted. So those are phases, steps, tasks, and actions. They make a temporal event. And the spatial events on the right side of the screen, you can see the anatomic region, like specific anatomy, general anatomy, and tissue characteristics. If we deconstruct a surgical procedure based on the temporal hierarchy, you can see that it's almost like Lego blocks, where a sequence of actions make tasks. Several tasks will make steps of the operation. A sequence of steps makes the operation, right? And we know that actions and tasks, they are present in every single surgical procedure. And as an intern, if I learn in one procedure, I can translate those skills to other ones. And similarly, some steps are similar in some operations. And if you learn how to do a step for one operation, when you have to do a different procedure, that comes as your muscle memory. So this is transfer learning. Similarly, what we do for humans, we can do for machines. And in a similar matter, we can also deconstruct the abdominal cavity, for example, could be any other cavity, into tissue characteristics, regional anatomy, general anatomy, and so on and so forth. And again, if you learn inflammation of the appendix when you're going to be doing a lap chole that's inflamed as well, that concept of inflammation gets transferred over. We did something similar, this is more technical now, for the data structure, where identified 4 major components with the data structure itself, the data use, the governance of the use, and the exploration. We found at least 20 use cases, and we also found that the metadata is the one that link all of them. Some of those use cases was majorly favored for scientific use, but could go all the way up to new technology product development. We also learned that the data through the life cycle has its many different facets, because some points of the data are different stakeholders interact with them. It's not just a single one that's going to be present. And that is the inception is at the operating room. And then after being transformed and turned into an application, it goes back to help other future surgeries. What about the community, right? We learned that through a scientific efforts and discovery with a computer vision challenge, right? Among all the scientific discovery, you can do computer vision challenges, multi-institutional collaboration, academia and industry partnership, creating standards for publication, and so on and so forth. But what we have done, and I think I'm very proud to talk about this, was a computer vision competition to benchmark who gets the best critical view in laparoscopic cholecystectomy. Similarly, what they do for Formula One, right? So in Formula One, what happened is, like, you have the rules and regulations for the competition, right? Which would be the governance of allowing to use the data, develop the technology. Then you have the teams, who are the developers, who have used those regulations to build their cars, let's say, to build their models. And they have a task. In that case, is who is the fastest, win the race without violating, the regulations. Here, what we did is many of you that are facile with technical language will understand this. For the other ones, I have to explain. A computer vision challenge is when we give a set of classifiers, could be just images or could be videos. And then we annotate them. When we annotate them, we will label them to say where they are. For example, I could give pictures of cats, dogs, and boats, and I name them cat, dog, boat. Then I give those images without the explicit label. And the goal of those models is to identify them with high accuracy. Here is to identify the identification of the critical view of safety. So we acquire close to 1,000, actually more than 1,700 videos from all over the world. We de-identify them. We assure that they were good quality videos. Then we train people to learn how to annotate. They got certified and they annotated those videos. And then we released those videos for the competition, which was Mikai, and was presented this past October in Marrakesh. So again, there's a video showing the critical view of safety up top. We have to be only two structures going to the gallbladder, the cystic artery and the cystic duct, with a clear background cystic plate. So see the importance of this, just going beyond the people who donated video and the people who participated. We had more than 10,000 unique visitors on this website from all those geographic regions. And if they read what was on the website, at least we're able to convey the information of what's a safe cholecystectomy. Then to create the challenge, we have the organizers, both surgeons and data scientists. And then we have advisors from industry, we have the annotators, we have the surgeons. So it's a very big community getting together for this effort. We train them based on diversity, and we got so many different technical aspects about the video acquisition platforms that we have. Some were laparoscopic, other ones were robotic, some were high definition, others were low definition. And also we had three major tasks: the CVS classification in general for the three components, also to account for uncertainty, and also for the robustness, like how certain you were that that was the CVS, and also can I make this robust and make applicable for different parts of the world. So we had 36 teams for 16 countries. Those are the results. And we end up having number one, number two, number three, which was a company, then a research lab in Germany, and then another research lab in California. We had several sponsors, all the strategics that you know, but also NVIDIA gave us a GPU that we gave to the first winner of this challenge. Then we were also invited to bring this to the second part, to Mikai 2025. It's going to be in Korea. And that we're going to be taking into account different things this time, would be computational efficiency, among others, to move forward. So how about education and training, right? Scientific meetings, such as this one, adding AI to medical school curriculums, dedicated fellowships such as the one we have at SAIIL, and publications are super important. At SAIIL right now, we have already a presence at GitHub, which is called SAIIL Public, where people can go over there and download some models. And soon we're going to be also making some data sets available. SAIIL is expanding. SAIIL is a multi-site. It was established Mass General in 2017. Now the new headquarters is at Duke University. Mass General is still a site, but now we have in Duke, Singapore. We have in Erasmus in Rotterdam, the Netherlands, and the University of Cologne in Germany. We also have put a lot of time and effort in understanding surgical governance, understanding that the most important part of this acknowledgement is the fact there is so many different stakeholders that are involving in designing how we're going to be regulating the use of the data and the use of AI models. Getting the legal framework together is super important, and especially because when you go internationally, there is all those different regulations, but domestically as well. Recently, we partnered with Train, which is a trustworthy, responsible AI network, where SAIIL is happy to serve as a surgical arm of Train. Train represents about 40 healthcare systems in the United States and 9 in Europe. So with all of that together, with the SAIIL network plus Train, it brought us a lot of work to do, right? How can we build that digital infrastructure to connect all those users? So we need to build that bridge, right, to cross this chasm. And this is the blueprint for the bridge. So we worked with some of our partners, developers, and this is called the Waterley map, which tells us what is commoditized and you should not be investing money in developing. You should just partner or buy or subscribe. And what is on the genesis that doesn't exist so much. For example, to the left of the axis is the genesis, to the right is utility, and similarly to the bottom, the value chain, what's visible, what's invisible. And we found that the infrastructure needs to be built, right? Everything else you can connect, can partner with annotation software partners, with cloud providers of security, and so on and so forth. But it has to be this unique infrastructure, this scaffold that allows everything to flow through it. So we call this a surgical operating system, right? And the surgical operating system, what it does is it allows us to do ethical and trustworthy data generation, model development, and validation of those models. It addressed the need for benchmarking and ethical considerations and touch on those four major points: the data privacy, the AI model development, the validation, and the governance of the data. So all of those points bring to this, right? This is like a very high level overview of this SAIIL SOS platform, which you have one line. There are all the different types of customers are going to be interactive with the platform, all the AI environments that are going to be present in the platform, from marketplace to Gen AI tools, data management, and the cloud platform for the orchestration of moving them through. Because they're modular, you do not need to be, let's say, your AWS or Azure or others. It would work for everybody, right? So you don't need to be changing your technologies. The other way to be seeing this, a functional overview of the SOS is, imagine this big like gray box with the orange box inside. That's the operating system. Purple are the people who are going to be interacting with the operating system. And it could be an individual surgeon, a clinical expert, a hospital, a data scientist, a researcher. The boxes inside, the one in light gray, they are the core part of the operating system, which is the data banking system and the model banking system. And the nice thing about them, the metadata in the data can be decoupled. So for security, and similar, the models and the model cards can be decoupled. So going back to what I said, what if we have an operating system for surgery? We will be able to do standardization, efficiency, and safety of the operations. Would allow us to have all those features listed over there, from like technology integration, analytics monitoring, communication collaboration, and other special features. But let me just show a few of them. One would be the data generation and management that would allow us to use all those terabytes generated every day and organize them in a critical fashion and maintain the data structure. Similarly, we would allow us to do data training, algorithm optimization, model testing, and allow them to continuously learn by benchmarking the improvement. It would allow us to regulate that as well, assure that they are trustworthy, benchmarking the technologies, like in Formula One, when they come up with the regulations. Like, for example, two seasons ago, and this season as well, Red Bull started as the best team. But because of the benchmark, and they were watching why Red Bull was so good, and all those other teams were catching up. And at the end, it was a very fair battle. We'd love to see this as well, where when technology is being benchmarked before going to the OR or after post-market, the goal will be that we will decrease cost and then we will increase efficiency, as like we're doing a free market. Solution management, such integrating all the different technologies for different vendors. Providing security and access control to who needs access to what. So besides this, this is creating a marketplace for cognitive augmentation, not for human replacement, right? On information, guidance, safety, and operational efficiency. Let me show you one of the experiments we have done that was back in Mass General. This is going to be a video of a laparoscopic sleeve gastrectomy. And then we're going to have a bar right in the middle. It's going to be the visual representation of the log probability that the events are happening in a correct fashion. And where red is very high probability and blue is very low probability, all the colors in between red and blue are mid-level probability. But let's just show a normal case, right? So we started the case right now, and you can see that the ports were placed, then the liver was retracted, the gastrocolic ligaments being dissected. And as the machine does that, also makes prediction what's going to happen for the next step, right? And if you look at this entire case is becoming within the normal range of the log probability. And at the end of the case, we have this very nicely created image that we call a surgical fingerprint. And the surgical fingerprint in general is very similar for a particular surgeon doing a particular surgery that went in a normal fashion. So next, we threw a curved ball where we gave a video, the same operation, but the patient had an open cholecystectomy first. So we need to take down the adhesions between the omentum and the abdominal wall before we can proceed with the procedure. And see how the machine interpreted this. Quite hectic, right? Takes too long. We already put the parts. What's happening next? I don't know. Like mid-range probability. Then, oh, I'm doing liver retraction, but then goes back to again back to the probabilities, and you can see that creates a hectic perception of that to the point that the probability is so low that doesn't know what's happening that deviated down to the bottom, right? Two different ways to see it, and this is an abnormal surgical fingerprint. And if this paper was published Annals of Surgery, and we can see that every time that we have low log probability, there was some abnormal thing that happened in the case, not necessarily something wrong, but was abnormal, bleeding, altered anatomy, lines of adhesions. So what are the future steps? Is to create a surgical video foundation models. And what do I mean with that? These models, they serve as the foundation base for training on large data sets, similar like what happened to large language models, the ChatGPT. And it would allow us to do video analysis, complication prediction, real-time guidance, and automation. And if we go back here just one second, and especially with new technology being presented right now, especially from the diffusers from NVIDIA, this is becoming true very, very soon. What we could do is by applying the standards that we already have developed and training all those videos through the entire network, both adding those building blocks from the temporal hierarchy and from the spatial hierarchy, what we can do is we can use techniques for transfer learning and then exponentially expedite the training of those models across the entire network to create perhaps an AGI soon in surgery. This allows us to do the benchmarking. Again, like I mentioned before in Formula One, if we have a better model tomorrow that's cheaper or more accurate, why I cannot just turn off the subscription of the other one and start using it? So you keep the developer on their toes and keep things marching forward, exactly what's happening with LLMs right now with all this arm race storage to the best one. And it's very important to think about it because all the hospital administrators, the people who are looking at finance are going to be asking, what is the return of investment? Is this sustainable? And there was a few ways to be, like creating data monetization, model co-development, create application subscriptions, being contracted for clinical trials. If your hospital site is mature enough, you could be doing clinical trials for artificial intelligence in surgery. And of course, be a site for pre and post market evaluation. So sounds like a lot of information. Looks like that there is no light at the end of the tunnel, but there is a lot of light us getting to the end of the tunnel. If we put all of these that I mentioned together, right, we can then start applying technology such as this that was also built in our lab that looks in the previous 15 seconds in the past and make predictions what's going to happen in 15 seconds in the future. Right. So here on the red line was the dissection of the callous triangle was happening, and the machine was making prediction what's going to happen next, and we see what's the highest probability on that. And if you can actually use technology such as this and then apply for those pre-analytics software, such as the one that Oracle does for Red Bull, we could potentially see something like this in the future, right? We could potentially create a conceptual, computational, collective surgical consciousness, right? In this consciousness, we're going to be able to tell us to stop before the complication happens. Then we get a normal surgical fingerprint, and then this patient goes home. So with all of this, I really think we are crossing the chasm soon with all the people who are embracing this vision and want to fight for like a better future for both the patients and ourselves. And that, I think that's going to be fantastic. So with that, I want to thank our team, the faculty of SAIIL, and also our current fellows and our past alumni. This wouldn't happen without them. And thank you very much. I would love to discuss further with you guys. Thank you.
Yeah, I mean, before anything, if anyone wants to ask a question, you're more than welcome to raise your hand or or speak. But one of the first questions we found is, in your data governance work, how important have you found data formatting standardization to be? Do you think neural networks and LLMs are advanced enough to take advantage of video data and other meaningful metadata that's stored in different formats?
Hard to say right now because we haven't like fully assessed this. Our team is working on trying to create some foundation models from a large data set that's being unstructured, and we have some preliminary results, but have not been validated yet. But I have no doubt that as those technologies get refined, and like I mentioned about the new diffuser from NVIDIA, this is going to happen very soon. So the concern of we have to have very well curated, annotated data that we to extrapolate to uh, may disappear. However, I highly encourage that the very initial data to create a surgical video foundation models has to be very well structured, very well created, like when we go to medical school, right? Because think about this, with LLMs and those like more sophisticated, especially the fine-tuned softwares, many people could start playing as a doctor very soon about making diagnosis, about prescribing medication with a high level of accuracy, right? You don't really need to have that much of a training. We know that those already have passed like the website, among others, right? And similar for surgery, you have like Gemini that they were able to train the model in YouTube videos and got some results, right? But that's not what we want for surgery, right from the beginning. We need to be the ones training that to make that very robust and solid. After that, people can fine tune in the way that they want.
Yeah, that's good to know. It would be so nice if we didn't have the interoperability problem, moving from one database to another, one data set to another. If we're able to incorporate all that, that would be so nice. Another question we had here, that the model was so cool, just being able to see what was in that normal range. Have you all been able to test, what about a case where the patient has like an anatomical variation? And so what the surgeon is doing is not matching the pattern of what is normal for
Yeah.
said surgery. Does the machine have problems with that, or is it able to see the variation within the patient and say, well, for this case, this actually is the normal? How does it handle cases like that?
It depends on the training, right? Right. For example, in the beginning, that case we showed was on purpose. We knew the machine was not trained to understand lines of adhesions. So therefore, this became the hectic prediction. And imagine, like, it sees the liver again, and what it thinks, oh, I'm going to be retract the liver. No, I didn't do this because this procedure, the next step has to be the dissection of the gastrocolic ligament. And then he sees the lysine, sees part of the stomach, and then sees some of the fat of the omentum, and thinks that opening the gastrocolic ligament, right? So it's like if you ask an intern, they have never seen a surgery before, the intern is going to say, wow, I can guess, but does not look normal to me, right? But then as you train the intern, you're going to say, yeah, it's not normal, but it's just an abnormal anatomic, variation, which could occur in that percentage. And that's how the technology will evolve, right? After then we train what's lines of adhesions, then the machine just add another tab, lines of adhesions or anatomic variation. And that's what we want to do with this large collaboration across the world, is that once some site can see a normal abnormal thing, and you train the entire consciousness, right? So next time a surgeon in another site going to do the operation, that we will know already what it is.
Hey, my name's Phil Jenkins. I'm a general surgery resident at OHSU, and I'm in the clinical informatics National Library of Medicine postdoc fellow as well. My question is, do you see this with computer vision being able to get to a point where you can use it for resident training and evaluation? A standardized enough model? I've been looking at this with operative notes and natural language processing, but I wanted to see if this is something that you're looking at with computer vision.
Oh, absolutely. And I think it's going to be on the very early applications because it has no implication with the patient care itself. So it does not need like FDA, approval. So I can totally see that happening. For example, even for the surgical fingerprints, your surgical fingerprint for doing lap choles or for doing lap appies, you will evolve over time, right? So we can actually start looking at the log probability of those events to happen in a particular surgery. It coincides with a PGY3 level or an advanced PGY3 level or like a PGY4 like low level. And not just that, we'll be able to critically see which part of that assessment was the one that gave you the lowest score, right? Then you can actually review the videos and find out where should we be improving. So definitely that would be one of the very first applications. And another thing is with the American Board of Surgeons now, moving forward toward to using video-based assessment for certification, right? We're not going to have enough surgeons to be reviewing all those residents graduate every year. So we will need to automate this process.
Hello, thank you very much for this presentation tonight. I'm a med student at Duke, so I'm I'm right down the road from where you are. But I know a lot of the work that Duke Health has been doing has been public-private partnerships with Microsoft. I know we're opening up a compute core over the next few years to kind of do some training of models on site. I was wondering, how do you see the relationship between public and private institutions, universities, kind of changing over the next 5 years, as these universities do more collaborations with tech companies and other things in the health tech space?
Yeah, it's going to be interesting to see, and it's hard to predict because some going to be like different variants of this, right? And for example, Duke is very pro collaboration with industry. Others, like for example, my former hospital, Mass General, not so much. And there is a lot of times like where you have like personal relationships, like a surgeon and a startup and things like that, end up bringing that. I think for this to be successful, it has to be doesn't need to be 50-50, but it has to have some like a foot in one side, another one the other side. And why is that? Is because it's much more fluid and easy to innovate into the academic settings because our fear of failure is much less, right? Our failures are not getting a grant or not getting a publication or whatever, and we're still being paid by our like clinical volume or by our professorship ranking and things like that. And similar for the students, right? You guys are already paid the tuition and going to graduate, and this is an exercise of like how to innovate. Industry, in the other hand, it cannot be that how can I say aggressive in attempting different approaches, right? Because if they choose a different wrong path and they don't get the minimum viable product in the market, it could be a ruin for that a startup, or for that big corporation compared to the other one. But they're also very good to understand when there is a good product coming from the academia, that then in the academia, the downside is that won't move so fast. It's going to take forever because of the conflict of interest, how much funding you have, who is running that product is not a expert, CEO or, CTO, is just a faculty person or a student, and is not going to be given the best attention. This then should move up to the industry where then they say, oh, that's a good, solid product. Let's make it successful, right? So that's why I see the pipeline happening, the innovations occurring on the academic settings, but then the partnership, the bridge, going to allow to transfer that to the industry. They're going to be successful outside the university.
Next, we'll ask a submitted question that was just submitted. If a surgical guidance system can be implemented, what are your thoughts on how future physicians can balance using these tools and human skills? How can we gauge trust in these tools' predictions?
Yeah, so it's a good question. It's a very common question as well. First, I mean, in the beginning, I think there'll be not much trust. It's going to be just like, oh, it's just saying what I already knew, right? And we're going to be working with the experts to get that calibration. But then later, going to get to a point that some people are going to rely on it, some people are going to become over-reliant, and the other one's going to become skeptical, right? The problem with the over-reliance is that doesn't matter whatever the machine says, you're going to agree with that. The skeptical, many times you're going to disagree with that. And we've seen radiology that when a radiologist read a film like an image like a breast mass or something like that, it has a accuracy. And then we see if we put two radiologists together, the accuracy goes up. If you have a machine, it has one accuracy, but if you put in a machine and a radiologist, also goes up almost equally as the two humans, right? If you learn how to use that properly, if you're not skeptical and over-reliant, it makes you better, right? But how to gauge that? You need to be educated, right? I think we need to be credentialed to use AI tools because AI is a tool like anything else, and tools are only as good as how much we know how to use them. Go back to Formula One, you put a bad driver on the best car, you're not going to get as fast, right? So that's why I think we should be mindful, should be how can I say, inquisitive about the technology, but also critical of this. And then we make the best judgment about it.
Hello, thank you so much for your presentation today. And I'm an MD PhD student from Mount Sinai in New York, and I've also been really interested on like robotic surgery. And I came to notice that like a lot of the progress that has been happening in the field, especially with like AI for robotic surgery, is like largely dominated by like abdominal surgery. And maybe that's like due to intuitive and like the Da Vinci robot being so like popular and like great at collecting data. And also maybe with like laparoscopy tools and like how endoscopy is kind of already built into how these data are collected. But I'm curious on your thoughts on like, have you seen progress in other specialties, other surgical specialties? Like, what do you think needs to happen in terms of like concerted effort to actually also bring in innovation to say other specialties that might benefit from these tools?
Yeah, I haven't done like a recent like update on what's happening in other industries such as neurosurgery, ortho, retina surgery, everything that uses image. But I know that just by talking to industry and consultants that this is actually happening. And the difference is because the amount of video that's being collected on abdominal surgery and thoracic surgery supersedes all the other ones, and that's where they're making the money right now. Because if you think about ortho, is for pretty much like stabilization guidance, know how far it's going to be drilling. For neuro, also think about what do you have there. You have brain matter, vessels, fluid, and blood, right? And perhaps the cancer that we're going to be removing. So there's not really much room to go in that direction. But now there are like coalitions of people creating like consortiums for neurosurgery, for ophthalmology, from all the others. The only problem that I see is that because they are like individual companies, I don't think going to be able to be translating what's being developed in one to the other one. And that's why like, I fear that's going to be kind of holding the development of that. But when you go back to the platform I was mentioning, if everything is developing on that platform that translate everything to a common language, then you can actually extrapolate knowledge from one field to the other one.
I have a question. Thanks for the presentation. I really enjoyed it. So when you're talking about your F1 example and kind of talking about how the entire system is very integrated, encompassing the provider, the developer, the hospital, insurance companies, and more, where does the liability go with complications that might arise in surgery going forward?
Yeah, so that's like an excellent question. So at the end is this, for example, the system is not going to be the owner of the application that's being developed, right? The application, it was developed by developers, and that then perhaps the developer or whatever other entity going to put that application for subscription utilization. See the same thing that happens to your phone, the iPhone, right? many of the apps are not designed by Apple, and Apple is not liable, for that particular application. Definitely, the liability could be for poor connectivity between apps and things like that. But once we get to that level, there's going to be so many safety guards that we're going to be putting together. But let's forget about who has the liability and the fault, but how to deal with that. First of all, I think training the operator, right? Like I said, you need to know how to use the tool, and you need even to know how could you question if AI is right or wrong, right? And then if a human is going to be questioning, say that AI's recommendation is a wrong recommendation, and what we are thinking that might be in the near future, before when the AIs get really, really good, would be for a second agent to come to do the arbitrage, right? Could be another human to say what's the right decision between this human surgeon and the AI, and eventually could be just two AI models independently coming up for that determination. And I can guarantee you, if two super AI models in the future tell a surgeon that you should be doing that after being heavily validated, I think the person going to do it, or the person going to feel very good if coming out the surgeon expert on another AI model that agrees, with the person. And the patient also should know that, because similarly, when you're going to undergo robotic surgery, there could have some failures on the robot, right? And the patient should know that. The patient is like is transparency and obtaining the consent, telling the patient what you're going to be doing, right? And if you do this, doesn't matter whatever technology you use, if you're well trained, I wouldn't be worried about those things.
It's a phenomenal point. That's actually a very hot topic discussion among our generation. We're always asking who's going to be liable, and it's a very eloquent way of putting it. With that being
People love
said,
that, yeah.
I'm sorry, go ahead.
People love to say those things, like who owns the data, who's going to be
Yeah.
responsible, those talking points. You just have to learn how to answer those questions, and then let's talk something that's more constructive.
And Dr. Meireles, one thing is that's honestly a hurdle for adoption too, right? There's this whole narrative of people being skeptical. Oh, I don't want to adopt it. I'm just gonna replace surgeons, but more so, how do we know it's safe, XYZ? And so it's a fair way of approaching that question.
Yeah.
And so, this is an amazing conversation. We want to thank you for taking time out of your day to provide such a clear and insightful overview of surgical AI. You've transformed such an incredibly complex topic into an approachable and engaging discussion using steps of your thought process, the Formula One analogies, and even giving a broader perspective on how it all ties together seamlessly. And one thing we thought was very inspiring is how you translate your expertise from nationwide policy development and data governance to actionable insight that ensures that AI is being safely integrated from the hospital setting to individual patient care. And we think this has been a phenomenal primer to the role of AI in robotic surgery in the operating room. And we just wanted to say, on behalf of the AI Med Trailblazers, thank you so much for sharing your forward-thinking vision and sharing invaluable perspectives with us today. For all those here attending, we have a little bit more for you. But yeah, once again, thank you so much, Dr. Meireles.
Thank you so much. Much appreciated.
And for those here, right, this is just one of the 20, 30, 40 different topics that we're going to be exploring. As you can see, we're bringing in some of the world's leading experts that bring in such fresh perspectives. You saw how during the Q&A, Dr. Meireles really, really talked about some of the hottest topics that our generation wants to know. And he unpacked it really well. So we're bringing in all these different topics. Next, we're going to be doing AI and entrepreneurship with startups. We're going to be exploring that with some different world leaders. And so we want you to be part of this. And so if you haven't already, join the listserv. If you've signed up for this event, you're already there. If you indicated yes, join our LinkedIn where you can see all of the different updates we're doing and our YouTube series. In our YouTube series, we not only have events like this, but we also have, we've been doing interviews and podcasts with different leaders, like short series podcasts. And you can also learn a lot from that, from things like cardiology to mental health, XYZ. And lastly, if you're interested in promoting and being a voice for this at your own program, whether we have people attending here from Duke, from Stanford, from MD, PhD. If you want to promote this to your generation and your organization, we encourage you to help grow the mission. We've added the link in the chat, and all you have to do is fill it out. And whenever we have these events, we can share it with your org, and also we can work together as a nationwide coalition and start doing things with all these leaders that are so generous to offer their time and insights. And so this is just the beginning. But yeah, we just want to thank you all so much once again. And with that being said, you're more than welcome to enjoy the rest of your evening. And thank you so much from the AI Med Trailblazers.